Our next speaker is Spero. He's going to talk to us on an evolving technique update, arthroscopic technique, salvaging bony Bankart fragments and getting them to heal. 5 steps in 5 minutes.
Thanks, Jerry. I think Dr. Wong and I are going to deal with arthroscopic management of bone loss. These are my disclosures. So let's start with the case report. This is an active yet brittle 50-year-old male who fell skiing and had a dislocation and then subsequent multiple repeated subluxations in the week prior to following up with a partner of mine in the clinic. Classic instability exam, apprehension, relocation. An MRI showed a big bony Bankart lesion like we see here. Both the coronal, the sagittal, and the axial planes all show a significant injury here. And what you see on the CT scan here is approximately 20%, probably 6, maybe 7 millimeters of anterior inferior bone loss. So we're looking at a situation here, first-time dislocator. He's unstable, but this is not a guy with a displaced anterior inferior glenoid lesion that we're going to let heal. He was actually sent to my practice for a Salvage procedure, but I felt that big piece of bone, we could do a nice job with that arthroscopically, and he's going to be the focus of our talk today. So what are we trying to do? We're trying to restore the glenoid tract, right? He had a moderate Hill-Sachs lesion, but where his big bone loss was in the anterior inferior glenoid. So restoring that anterior inferior glenoid, acute anterior inferior glenoid bone loss is going to allow us to restore his tract and render him stable. So lots of different ways to do this, open, arthroscopic. You could certainly go straight to a Salvage, but I felt with that piece of bone and that location, with the acute nature of the injury, we could do a nice job for him with an arthroscopic osteocapsulolabral reconstruction. So just a couple technical pearls. I like to use the anterior superior portal for the scope. We can do the inflow through the back or through the top through the scope, and then the anterior inferior portal is one of our big working portals. You can see a great look right down the neck of the glenoid and the capsulolabral injury there. Release is going to be very important here. Use an elevator, use a shaver, really get that bone prepped out real good. These are 2 other patients up here. This is the patient we were dealing with here, so you see this big chunk of bone. And basically what we want to do when all is said and done is we want to be able to see that subscap through the defect, because that way we've kind of floated that entire osteolabral construct and be able to get sutures around it. So I like to get down past 6 o'clock. Numerous speakers have said that today, and that first bite of tissue kind of get into that posterior inferior band of the glenohumeral ligament. Suture passing, all kinds of methods here. You can use a suture shuttle like here. Here I've got a grasper in the anterior superior portal pulling it into the direct suture passing device. You can see what we're doing there, so we can go circumferentially around. You can also use knotted anchors right through the bony defect, nitinol wires, and all kinds of things we can use to pass. Just dealer's choice here, whatever works for you. Anchor placement is going to have to be right on the glenoid face. Remember, we're missing bone here. To restore this anatomically, you don't want that anchor on the neck of the glenoid. You want it on the face of the glenoid. I like a knotless technique here, a little luggage tag around it. It's stable, and it use a tape so it doesn't cheese cutter through the osseous fragment. So just to rehash a little bit, I like 2 anchors for the glenoid defect, 1 below and 1 above, so typically 4 anchors total. Release past 6 o'clock so you can get the posterior inferior band of the glenohumeral ligament. I like to pass all my sutures first before I start putting any anchors down, because that way I'm not blocked out. I'm not starting to tighten myself down, so I can get these nice grasps of tissue around the bone. I do add an interval closure on many of these to help back up and load share with the repair, especially when the arm's in external rotation. And we got a second look here. The guy had his dog rip his arm as he's trying to put it up into his pickup truck bed 3 months out. We expected the worst, but feeling pretty good about that repair here on MRI. And here, you saw the pre-op. We actually were able to go back and do a second look on him because I had to fix his supraspinatus 8 months later. And you can see the second look here. So kind of that typical fibroproliferative fill that you would see at any fracture through the cartilage, but feeling pretty good about it. You can see the sutures are intact here, nice, stable, kind kind of a typical look here. So I think, you know, as the title of the talk says, we think we can get these to heal with proper technique. So just key points: good release, good mobilization, good capture of your bone, depending on the device you want to use. I usually like direct suture passing, but a shuttle's pretty helpful around these as well. 4 anchors, 2 through the bone if the fragment's big enough, 1 anchor above, 1 anchor below. Get that glenoid nice and denuded. Remember, it's kind of a fracture operation here, not so much a soft tissue operation, so you want those bones to heal. And then I like to throw in that interval closure. I think it helps load share, especially when they're stressing that arm out in external rotation during their early rehab. Thanks very much.